Good afternoon, everybody. I hope you're still awake, and would like to thank the organizing committee one more time. So my talk is going to focus about managing of type 2 diabetes during Ramadan. So I have nothing to disclose at this stage. Before I go into Ramadan and management, I just want to go back about the fasting and glucose excursion, a little bit back to basics of what happened when we eat. And let's just go through a phase when, in the first 4 hours after we eat, which is the postprandial phase that we go through. What we do with this period is that we start to build up glycogen storage and use all these glucose to use it in the post-absorptive phase, which runs for about 4 to 10 hours, where we break this glycogen and start using for a source of energy. But over 10 hours, then we start to enter into a fasting state. And after the 10 hours, we start to break down fat, we might break down protein, and go through a process of gluconeogenesis that we all know in order to be able to to make glucose. But this process is impacted by many things throughout the day, but particularly during Ramadan is really important. The quantity and type of food we consume, if it is high in protein, high in carbs, and how much did we consume exactly. The fasting hours is impacted as well. How long since the last meal, how long is the fasting since the last meal, and how long we need to fast during Ramadan. And very critical in my point of view is physical activity. Because the more active the person is, the more likely he's going to consume the glycogen stored, the more likely the person is going to get into a fasting state and go through gluconeogenesis earlier than anybody else. And obviously, as you can imagine, medications plays an important role in all of these. So the glucose excursion and how long will it come us to enter into fasting and the fasting state impacted by many things, as I can show you here. And a typical, and I think this data came from the UAE sometime, a typical iftar in Ramadan in the Gulf area is estimated to have between 1,400 to 1,600 kilocalorie. That is about 160 grams of carbs, which is more than a normal body, say normal, somebody who doesn't have diabetes, can metabolize per minute, much higher. So we expect even somebody with no diabetes to have a surge in the glucose after a typical form of iftar. So diabetes is a heterogeneous condition, and we all know that. But Ramadan is not a homogeneous condition as well. So there are multiple different forms of diabetes, multiple phenotypes, multiple medications, and you can think of the combinations, and I think you will find many forms of combinations of medications that you can use. And Ramadan is not a homogeneous condition as well, because for me, Ramadan means different things for different people. They're coming from different ethnicities, we have different fasting hours, we have different working conditions, and people do different activities. So some people might be working work office that is reduced, some people have to be in the field, so it's not all exactly the same. And if I take you back to 2017, which is Ramadan came in June, July at that time, the middle of the summer, what you can see over here is those people living in New Zealand, Argentina, South Africa, they were only fasting for about 10 to 11 hours. They've barely entered the fasting stage at that point in time. If anything, they probably during Ramadan, they don't need to do any adjustment. They don't need to worry about anything. They've barely ever actually just kissed the fasting. But if you look at those who were fasting in countries up north, look at United Kingdom, 19 hours, like Iceland and Greenland, 21 hours. Those people have a huge problems in order to maintain their glycemia, in order to avoid hypoglycemia, and it's not very challenging for them to fast. So fasting hours and fasting conditions vary a lot. And this is one of the CGM data that we have on a group of patients that we're running in one of our studies. Those patients had to be on either a basal insulin or a sulfonylurea, and we just collected these data. And what I would like to point your attention to is what happened to the glucose at 6 o'clock in the evening. How high does the glucose shoot up? How long does it take for the glucose to come back after a typical meal? And this is one of many. And we have, you can see that in this patient particularly, so we're talking about 6 hours before we see any drop in the glucose. And then later on, there is another meal, which is suhoor. And we have currently another study with which we looked exactly the same CGM patients, again, similar cohort of patients, but this is a group which is a computer scientist who tried to put all the data together and give us a smooth graph for us to understand what happens during Ramadan. And the orange line, which I believe is orange, is the glucose profile outside Ramadan, and then this kind of purple is the glucose profile during Ramadan. And you can see that their glucose seems to dip just before iftar, shoots up after iftar, and it takes a good 5-6 hours before it starts to come down again back to its baseline. So the glucose excursion varies a lot. And we have data on those groups in terms of their activity. We capture it by Fitbit, but we're not ready yet to present this data. Now we're entering to recommendations for Ramadan. I believe we're living in an evidence-free area. And the reason why I say that, because what we have in terms of guidance is based on expert opinion rather than based on hard evidence per se. I'm going to show you what I mean by that. So we don't know what do we want from our clinical studies in Ramadan. What are we looking for in order to say it is safe to fast Ramadan? And I get every one of you can think about what is your most priority when you're fasting Ramadan. Is it hypoglycemia, or is it hyperglycemia, or is it complications from hyperglycemia? And I don't think we have a of what we're looking for. And exactly, most of our data are observational data, happen in a certain population, could have a very good internal validity, but to apply this observational data to a different cohort is very challenging, as I told you, based on what we know about the fasting conditions. If we have randomized control trials, majority of them have a small sample size, majority of them lack power in terms of giving any evidence. And then we have many studies that are comparing agents versus sulfonylureas, and the answer is, are they good in terms of hypoglycemia? And we learned more from these studies, not particularly versus sulfonylurea, but we learned about the agent per se. And we don't have a method to correct for all the variables I'll tell you about. Fasting hours, how are we going to correct for that across populations? How are we going to correct for activities? Because these are important variables that can dictate how the person behaves to the medications. Finally, self-reported hypoglycemia, and I put self-reported hypoglycemia outside all these charts, and I'm glad Dr. Ramzi Ajani yesterday pointed out that self-reported hypoglycemia doesn't actually capture the truth for the hypoglycemia. If anything, maybe the person who reported the hypoglycemia has a better awareness of hypoglycemia, that's why they're recording it, and we're missing all the unawareness over there. So we're building off these, and that's why I think we have to learn from other studies and try data outside Ramadan and try to speculate how things are working. So for the next few slides, I'm going to go through the common medications and what the guidelines and recommendations from the data line say, and how we can learn and adapt what we know about these agents. So we know metformin, our favorite agent, works on as an insulin sensitizer at the level of the liver, and it reduces the net hepatic glucose production. And if you want to think of these, we have to think about fasting and postprandial. So it has a good impact on fasting blood glucose, has a good a small impact on postprandial glucose, and generally speaking, when you're using metformin alone, there's a low risk of hypoglycemia. And the UKPDS data told us patients on single agents, which one of these patients are at high risk of hypoglycemia? They're in single agents. Young patients, lower BMI, low baseline fasting blood glucose, low baseline HbA1c, and those who have a huge reduction in their HbA1c are at high risk of hypoglycemia. But when you look at the numbers of metformin, you find that the rates of hypoglycemia in these cohorts, we're talking about 6 years, at the duration, I think about 6 years, the rate of hypoglycemia in metformin group is the lowest. However, if hypoglycemia is going to happen, it's going to mostly those patients that I just mentioned are at the high risk of hypoglycemia. So the recommendations from the DAR Alliance about metformin are actually simple. You don't need to adjust for the doses. You just need to look at the timing of the doses and split them between iftar and suhoor. However, from my point of view, a word of caution has to be how long the patient is going to fast and what type of activity they're going to go through, and take into account other factors, because the longer the fasting, the more active the person is, they're more likely than anybody else to have a hypoglycemia. And what's the control? So sulfonylureas is the most second common agent that's been studied. We know that sulfonylureas just press on the pedal of the car, just keep pushing the beta cells, produce insulin, uncontrolled manner, impact the fasting and the 2-hour glucose. And they have high risk of hypoglycemia. But not all sulfonylureas are the same, they're different. So gliclazide, whether a regular form of or gliclazide MR, they work about 12 to 24 hours and 80% of it excreted by the kidneys. The other agents have a 50% excretion by the kidneys and they're kind of a longer duration. The risk of hypoglycemia reported outside Ramadan settings are actually different. It's much lower with gliclazide than with the other two agents, glimepiride and glibenclamide, which is the other commonly used. And if you look at evidence, when you look at patients who are treated with sulfonylureas, you'll see overall 10% of the patients will have hypoglycemia. Again, not all the same. Gliclazide has a lower risk of hypoglycemia compared to the rest, and even severe hypoglycemia. Not huge difference between the agents in terms of severe hypoglycemia, but the risk is could be about 1% of those patients. So, and when you look at combining sulfonylurea with metformin, you'll find that the risk of hypoglycemia is high up there with all the agents of sulfonylurea, but gliclazide seems to be the lowest offender, if this is the right term to say, in terms of hypoglycemia. But all the rest, they drive up the hypoglycemia. So who's at risk from this meta-analysis for developing hypoglycemia? And that's what we need to learn from as well. Those over the age of 65 with the longer duration of diabetes, with the lower HbA1c, who has renal impairment, and after exercise activity, they're more vulnerable to have hypoglycemia. And if they missed a meal, and that's in the meta-analysis, they're high likely to have hypoglycemia, combination with insulin and combination with the repeglanides. So patient with Ramadan, they miss a couple of meals. So there are observational data that looked at self-reported hypoglycemia, and they looked at symptomatic versus documented, and about a quarter of the patients on sulfonylureas actually report or document report symptomatic hypoglycemia. And again, if you look at various agents, you'll find the rates of hypoglycemia with sulfonylureas are sizable. Regardless of whatever study you're looking for, again, gliclazide seems to have the lower risk of hypoglycemia compared to the rest. So the recommendations are, when it comes to sulfonylurea, if you're taking once a daily dose, you may reduce the dose. If you're taking 2 daily doses, you should reduce the suhoor dose. I think, and then there is a recommendation which I think makes sense. If you have to use sulfonylurea, gliclazide will be the least offender. But I think sulfonylureas with any combination, if not used in a single agent, with any combination, the dose, in my point of view, using legal terms, should not, it must be reduced. Because if you look at studies that looked at risk of hypoglycemia when you're combining any agent with sulfonylurea, the risk of hypoglycemia most of the time increases by 50% to 2, 3, 4 folds. So our patients could be in any combination. So I think whenever sulfonylurea is in a combination with anything else, I think that those should be halved. And I think we should, if you try, you can use gliclazide instead. Now, DPP-4 inhibitors, they're incretin-based, and we know that they mostly work in the postprandial glucose excursion and have very modest effect on the fasting blood glucose. And generally speaking, they're low risk of hypoglycemia. Even when you combine them with vildagliptin, with metformin, you'll find that most of them are within the line of unity, not increasing the risk of hypoglycemia. So there are some studies looked at sitagliptin, vildagliptin, again, self-reported hypoglycemia, reported the rate between 3.8 to 8%. Kind of a high rate, if you ask me, because if you even look at some of the sulfonylureas reporting, they were not high. However, again, I think every study has to be put in the context, when it was done, where it was done, how long the patient have been fasting for, and what they were doing before we conclude anything from them. But the recommendations are don't change the dose, keep them the same. But a group from Jordan last year did a study, pragmatic study. They disagree with these findings. And what they did, they took patients on metformin, glimepiride, and metformin and vildagliptin, And they either left them on the same doses, or they halved the glimepiride, halved the vildagliptin on the other group. And they were looking at, again, self-reporting hypoglycemia. However, with this study, they're more disciplined in the time they're going to monitor the glucose, fixed timing throughout the day. And what they reported was a reduction in hypoglycemia in those where you lower the dose, even with vildagliptin. The rates were actually quite low. However, the problem with the studies is that because they have 4 different groups, they ended up with very small numbers in each group, and that gets you to question about the validity of the study. The numbers are very small. However, they raise the question of should vildagliptin be reduced. So SGLT2 inhibitors, again, we just need to have a quick peek on how they work. They work on the excretion glucose in the urine, block SGLT2 inhibitors. I'm not sure if you have SGLT1 partial inhibitors like canagliflozin, but Cana can reduce glucose absorption. We don't have Cana in Qatar. So the impact is in fasting, modest on postprandial. Cana has a better impact on postprandial hypoglycemia, and generally they're low risk of hypoglycemia. And we know they work on the amount of glucose being excreted in the urine. So they get rid of about 30% of all the glucose that are being filtered in the urine. And that really depends on very powerful ones. So a single dose of empagliflozin can lead to about 8 grams of glucose being excreted over a period of 3 hours. And that's regardless whether the patient been on chronic treatment or not. But that depends mostly on 2 factors: renal function, so the higher the renal function, the more glucose, and the HbA1c. The higher the HbA1c, the higher the amount of glucose filtered, the more glucose is going to be filtered in the urine. And the usual worry with those agents is thirst during Ramadan and hypotension. And do we have studies? There is a randomized control trial, and that's been done, compared it to sulfonylurea. And they were looking at hypoglycemia, which I'm not sure we're particularly worried here about SGLT2 inhibitors. No power calculation was done in this study. They reported a 6.9% low hypoglycemia with SGLT2 inhibitors. But more interested here in the postural hypotension, reported by about 14% of those patients. And about 3% of them, 3.5% of them were feeling recurrent thirst. We have observational data on canagliflozin, and again, it compared within the observation. They again compared it with sulfonylureas. I'm less worried about hypo, more worried about hypovolemia and thirst. Again, a word of caution: this agent should be, you should think again about many things. So the recommendation is not to change the doses with SGLT2 inhibitor because of the low hypoglycemia. However, I will recommend thinking about using these doses. Those patients are high risk of hypertension above the age of 65. If you start, you have to start 4 weeks before Ramadan, because all these symptoms tend to settle a little bit within a couple of weeks. But starting before Ramadan, patient will not thank you for that because they will be pumping out large amount of glucose in the urine. They'll be thirsty. Think about what the patient is doing throughout the day. If they have exposing to sun, they have to be working all the way. They're high risk of dehydration. They're going to be more at high risk of hypovolemia and dehydration. If there's a concomitant use of diuretics during Ramadan, things can get worse and they can get drier. And if there is excessive thirst during Ramadan, you might think of holding this medication, or patient doesn't have to fast if you can't hold it. But this is a problem that some of the patients do face. Now, TZDs, there isn't too many data around TZDs. Again, we're not worried about risk of hypoglycemia. There was a study that looked at randomized control trials. Again, very few numbers enrolled. No risk of hypoglycemia. But in this study, those patients in Ramadan, they gained 3 kilograms of weight. I probably would not give them pioglitazone just for this reason. You go into Ramadan to lose weight and you're suddenly gaining 3 kilograms. Not a good thing to do. Anyway, pioglitazone have a low risk of hypo. You don't need to modify the medications. Now, we're going to come to the GLP-1 receptor agonist here. They work in different ways, as you all know, in controlling the appetite, controlling the glucose insulin production. GLP-1s, there are multiple of them, and they're broadly divided between short-acting and long-acting. Exenatide and lexazenatide are the short-acting ones. They have a very powerful impact on 2 hours postprandial. They have a very small impact on the fasting glucose, while the long-acting have exactly the opposite. What I'm mostly interested in here is that the rate of gastric emptying is different, and the rate of nausea and vomiting is completely different in this cohort. Do we have data in exenatide? We do have some studies. It's observational data, very few numbers. The risk of hyperglycemia compared to sulfonylureas was low. Lexazenatide, there is a randomized control trial, looked again as lexazenatide. It has to be given, all these agents has to be given before food. And the recommendation is low risk of hypo. You don't need to change the doses. However, this study was, again, underpowered study. Where they were supposed to recruit twice these as much. Liraglutide, there was a randomized trial which was quite powered trial that was that showed a low risk of hypoglycemia, comparing it to sulfonylureas, more or less. But the hypoglycemia dose is quite low, so recommendation is no dose changes. We don't expect any of these problems with dulaglutide and the rest of them, and there's no recommendations for dose changes. However, that's what I would like. So the rate of nausea and vomiting in these agents are actually quite high when we're starting them. And this is data from the SCALE trial, which is looking at the rate of nausea and vomiting will be around 5% and stay around that. But it takes about 12 weeks to about 20 weeks before this settles, the frequency settled a bit. Similar data from exenatide. Exenatide is around 10%. And it takes a good 22 weeks before it starts thinking the frequency of it settles. And liraglutide about 14 weeks as well. I think we're looking at a survivorship bias, though, with all these numbers, because those are the patients who continue to take the medications. That about 20% of those patients stopped, 15 to 20, more with exenatide than less. So the nausea and vomiting at the start is much higher than what these reported. So the recommendations are, you can use this agent, you don't need to do any adjustment, but you need to start them 2 to 4 weeks before Ramadan. And here, where I beg to disagree, based on the data that I can show you, that you need to start them way ahead because of the nausea and vomiting is going to hit them while titrating them during Ramadan. How about basal insulin? General recommendations about basal insulin is to reduce the dose by 15 to 30% and take it at iftar. For bolus insulin, the recommendation is take your normal dose at iftar, and I don't know what's normal dose, which is one, is the breakfast, lunch, or dinner, and then reduce the dose by 50% in suhoor. Based on the evidence we're seeing from the freestyle library, I think the dose during iftar should be increased more than their usual meals. So I showed you this graph again. The patients are more vulnerable to hypoglycemia towards the end of the day. That's why basal insulin, glargine and detamir, old ones, were given before iftar. And I've shown you the huge surge that happens in these in the postprandial glucose. So I don't think we're using MPH anymore here, but glargine and detamir have a tail end, and they don't stay for 24 hours. So giving them before iftar, you get the benefit of this tail towards the end of the fasting, so you avoid the time where they are more vulnerable to have hypoglycemia. The thing which I don't know, and I'm not sure if you have an answer for, is what's going to happen to our patients with degludec and glargine U300, because they don't have this tail end during Ramadan. And do we need to reduce the doses further at the high risk of hypoglycemia? We need to have a little bit more data here. But it just would be a word of caution. I don't think you need specifically to give glargine U300 and degludec at iftar time. Mixed insulin is straightforward. If you're taking once a day, keep taking the same dose twice a day, take a normal at iftar, and then half the other dose at suhoor time. So this was a quick overview of what have been the recommendation, what I think about these recommendations generally. But overall, I think when you're adjusting the medications in Ramadan, it should be individualized if we can. And I think we have very, very few good clinical evidence and that we can actually use. We have to use all expertise and what we learned from all other studies. Always consider the age of the patient, comorbidity, duration of diabetes, and concomitant medication use. how would they come to work together. We can use data from other studies, it doesn't have to be Ramadan, and look at the risk of hypoglycemia and speculate from them. And from my point of view, what the patient does during fasting hours is really, really critical on how you want to adjust the medication, because the more they are active, the more they're going to go into fasting state earlier. And you have to exercise a very good clinical judgment. So I'll stop here and thank you.